Good morning, everybody, and welcome to Guildhall Chambers. I'm going to speak to you this morning about decision making in relation to injuries and possible treatment after an accident has taken place. It's a question of to have or not to have. There, you will have seen some one page of notes, I think, which you're welcome to get from the clerks, which just set out the cases which have taken place from 1920 to 2022, the main cases which deal with this area. I think the broad overview is that in many cases, certainly in the early decades when these rules were discussed, the court was dealing with men predominantly of working age who had many decades of work ahead of them. And the language employed by the courts, even from those early days, exhibits a lot of the patrician, paternalistic attitudes of the time. And that goes right up to Lord Denning in some of the cases in the 70s. More recently, there seems to have been a slight softening of approach. But by the same token, as I'm going to say, we can take nothing for granted. In every case, for a claimant or defendant, you really have to make sure that you understand the principles and don't take anything for granted. So the two issues, the first one I can deal with quite quickly, and that is where a claimant who's injured wants to seek out some radical or controversial treatment. I think the simple principle here is that providing there is a body of medical opinion who can be brought forward to have and can be shown to have advised the claimant that a particular type of treatment is recommended or may help, then the threshold of what is reasonable is going to be judged very low. In other words, the claimant can make the decisions he or she wishes, largely speaking, without criticism. Can I just deal with a couple of recent instances I have had in pain-related cases, which I think probably exemplify the problem that people have. First of all, I had a case where a guy of 62 wanted to, he suffered a pretty minor RTA, but he developed CRPS in his lower limb, just one lower limb. He was a very intelligent, highly paid HGV driver, a very specialist guy who was earning excellent wages. And the diagnosis of CRPS, although we know that it complex regional pain syndrome, we know that that is a diagnosis of exclusion. We know that there's a lot of controversy about it, but this was a nailed-on diagnosis. And the claimant, age 62, was very much a problem solver, and he wanted to have his leg amputated because of the chance he could rid himself of the severe pain he was experiencing. Now, I was pretty concerned because of his age, because he had type 1 diabetes, and because he'd had a heart attack the year before, that he really wasn't a great candidate for elective amputation surgery. Nevertheless, he went to a private provider. I won't name the private provider, but there are a couple of groups of people in the country now who will perform elective amputations. And he went through a multidisciplinary process, and he decided that he was going to go ahead. Actually, a rather interesting thing happened in that case, which is that one of the defendant's experts, who hadn't yet reported, wrote a letter to the claimant solicitors to express concerns which aligned pretty much with my concerns about the claimant's suitability for such invasive surgery. In that case, I managed to organise a conference at very short notice with Gareth Greenslade, who was the claimant's pain expert. And he's a very, I think, a very empathetic clinician. He's recently retired, a good expert, and he reflected the same and agreed with those criticisms and concerns. So the claimant was going to rethink that decision. Unfortunately, he passed away 2 weeks later of COVID. So it was a decision taken from him. But that was an interesting example. In that case, had he gone ahead, he would have potentially had difficulties with the surgery. But no one, I think, would have criticised him for going ahead with the surgery, even though the consequences could have been dramatic. It might have made his claim considerably bigger. They might have made his claim considerably smaller, as he may have passed away. The second example, slightly similar, a man of 37 from a manual background who has had an elective amputation of his lower limb. Again, a unanimous and uncontroversial diagnosis of CRPS. He has had the amputation funded by the defendants in that case. But now, of course, the defendant faces a massive bill for lifelong prosthetics. In his case, interestingly, despite the risks when you have amputation of phantom limb pain and/or that CRPS can spread to the contralateral limb, quite typically. I mean, it's rare, but typical within the rarity, or to one of the other lower limbs. In this case, although he has some lower limb pain, the claimant doesn't have any CRPS pain, and his life has been transformed. He has an osseointegration implant, so he will have top quality prosthetics, and the promise is that he's going to have a very successful future, including getting back to work. So the costs in that case for the defendant are going to be in relation to prosthetics rather than earnings. But those are two cases in which two people wanted to make decisions about their treatment, and I don't think that the court would have criticised either of them. If you have a case in which a claimant or defendant, where the claimant wishes to undergo some quackery or some extremely experimental, difficult treatment, or perhaps treatment overseas, I think from both sides, you need to try and bottom out a very strong professional basis for it. But at the end of the day, I think the threshold will be low, the threshold for criticism of a claimant. So if you move on to what I'm going to deal with for the rest of the talk, which is an unreasonable refusal, unreasonably declining treatment. These are situations in which there is evidence from medics on either side, but typically from a defendant medic in the history of these cases, that the claimant could have treatment which would cure or improve his or her symptoms. So the question is, at what point, on which side of the line does the decision-making fall? Who bears the burden of proof? What are the consequences for the claimant of not going ahead with treatment which is recommended? And we've got a whole array of issues to deal with, but the first and most important issue set out in the slides there, I say you must forget the dangerously simplistic rule of thumb that no one fails to mitigate by failing to undergo invasive treatment. The cases that I'll refer you to are replete with examples where claimants were actually criticised or their decision-making was scrutinised, even where they were faced with treatments such as spinal injections and a foraminectomy in one case. In another case, which is particular, I think it's an outlier, believe me, but in one case, the claimant declined mental health treatment, despite what Lord Denning said. He said that there have been tremendous advances in the treatment of mental health. This is in one of the cases, I think in 1954. In that case, the claimant declined electroconvulsive inpatient therapy, and his damages were curtailed as a result of that. It's a fascinating case, which I'll touch on later on. And it's a case in which Rose Heilbronn QC, who's one of the outstanding female barristers of her generation, was for the claimant and lost that argument. So the claimant's damages were curtailed because he didn't have surgery. But the questions for the court when weighing up whether a decision not to have treatment is reasonable or unreasonable are as follows. But let's just take a step back for the principles. If the claimant's refusal is not unreasonable, then the court will compensate in full whatever the consequences of failing to have the treatment are. So it might be a worsening of a condition, it might be a step change down in a condition, or it may just be that a condition which is presently acute becomes chronic. But the court will compensate in full for the consequences. Interestingly, if the claimant is likely to have the treatment in future, then the court will have to weigh up whether the claimant will have that treatment or not, based on the evidence, the likely outcomes of that treatment, so complete success, what you might call relevant success, i.e. relevant just for the issue which is being addressed. So it may be that there are a host of reasons why a claimant can't work, and the accident-related reason could be cured, whereas others couldn't. And that's another consideration. No change and or failure of the treatment. So in a case where the claimant's going to have treatment in the future, the court has to weigh all that up. And interestingly, there's a case in 1995 called Thomas versus Bath District Area Health Authority. And this is a case of His Honour Judge John Weeks, who was a Chancery judge in Bristol. Very, very capable guy and a former neighbour of mine in London. This was a case in which all the parties agreed that it was reasonable for the claimant to decline spinal surgery while she was bringing up her children. But the defendant felt that there should be a considerable discount on her overall damages because the fact was she was going to have the surgery in the future. So His Honour Judge Weeks actually made just a 10% deduction to the 100% value of her claim on the basis of weighing up the possibility that she would have the treatment and the success in the future. He considered that she would have the surgery in about 6 or 7 years' time, and it would probably be successful, but he still only made that modest deduction. The Court of Appeal rejected the appeal on the basis of the judge's reasoning and the fact that the judge had had the unique opportunity to evaluate the claimant and the experts. So you can see there, it's a bit like the Herring and MOD case, where we talk about loss of earnings and then taking off a 10% figure at the end of the process of rationalising the loss of earnings. In this case, His Honour Judge Weeks thought this lady would have surgery in 6 or 7 years, but because of a whole variety of considerations, he only knocked 10% off her total damages. And that was, I think, a very humane decision from the claimant's point of view, but you can see why the defendants would have been pretty cheesed off and may well have thought that they would have done better, certainly on appeal. But it is a feature of these cases that, with one exception that I'll come to in a moment, the Court of Appeal have not gone behind the findings of fact or the applications of fact of the first tribunal. So just going back to my questions, if, and this is the overall sort of principle in these cases, if unreasonably, and of course unreasonably is the key concern, if unreasonably the claimant will not undergo treatment, that will restrict the claimant to recovering the level of damages that he or she would have expected to recover if the treatment had been pursued. Now, that's one of Lord Denning's cases. Now, I've added there and succeeded, because in a lot of these cases, experts have given their opinion in court, and the court has adopted that opinion. So in several of the cases, experts, and in 2 cases particularly, a defendant's expert said, look, I think that there's a 90% chance that I can give the claimant back good use of a hand, or that he'll get back to work and such and such. Now, when making the decision that it's unreasonable of the claimant to have refused that surgery, the court has then curtailed the damages. So what it's actually finding is that even where there's a case where the claimant's turned down surgery with a 90% chance of success, surely there should be a discount for that 10% in which that operation would fail. But you'll see time and again in the cases that that isn't the case. And I think both sides need to be aware that the point may not have been taken in several of these cases, and that had it been taken, I think the claimant would have done slightly better, just because, for example, if there's an 80% chance that spinal injections or spinal surgery will get the claimant back to working in a manual job, then there's a 20% chance it won't. And that should be taken into account when calculating damages. So the test. The first and important point to note is that although the courts have actually vacillated on who bears the burden, it's now absolutely clear certainly from 2002, but it's been sort of on and off clear and is now beyond doubt that the defendant bears the burden of proving, broadly speaking, it would be unreasonable to the extent that should impact upon damages for a person in the claimant's precise situation to decline to undergo the particular treatment suggested. So the elements of that test: unreasonable refusal. As I've said a moment ago, it's important to get it right first time. In every case except one, the ultimate appellate tribunal has upheld the factual findings of the court below. Obviously, they're very ready to go behind factual findings, but also the application of those findings. The only exception concerned the slightly eccentric judge, His Honour Judge Simpson, who sat at the Mayors and City Court in the 90s, and I had the dubious pleasure of appearing in front of him many times. He was a man who required counsel to read all of the evidence to him in interlocutory applications. And he was, by the way, the spitting image, in fact, probably the inspiration for Grandpa Simpson. Anyway, in one of the cases, he made certain findings of fact and then applied them, and the Court of Appeal upheld his findings of fact but disapplied them. So that's the first point, a question of fact. The second is the burden of proof. And an interesting quote from John Laws, LJ, in a case called Samuels. Then what does the burden of proof actually mean? Well, it means the defendant must put forward a concrete case to demonstrate what the claimant might reasonably have done but failed to do. So it may sound stupid, but from a defendant's point of view, you have to identify the precise failure, the precise treatment that the claimant should have undergone. Very often it'll be obvious, but sometimes it will be nuanced. And sometimes there might be options, and you need your experts to comment very closely if there are alternatives, to comment on them and comment on the prospects, comment on the risks, and comment on the likely outcomes. So let's just have a canter through the test over the years. As I say, in the note that I've produced, I start in 1920 with a case of a miner called Mr. Kant, and we finish with a fine artist in 2022 called Mr. Mathieu. And in between, there are a raft of cases. One of them, Mr. Marcroft, he was the unfortunate gentleman who declined to undergo electroconvulsive therapy, and consequently his damages were limited. Then in 1974, we have the case of Mr. Morgan. This is a case where one of the surgeons, the defendant surgeon, estimated that there was a 90% chance of success in relation to surgery, and that was back surgery for a lighterman. The gentleman's friends, who were non-medical, but they said, oh, they'd had surgery of different types, and they told him they thought it was a terrible idea. He was scared to death of having surgery. And the evidence was that there was no 100% guarantee. Whenever is there, but there wasn't a 100% guarantee. but one of the experts said there was a 90% chance. And in that case, the court thought the claimant was unreasonable in refusing treatment, and therefore his damages were limited. An important thing to come back to is the claimant's reasoning there was that his friends had told him not to do it, and he was fearful of surgery. If he had been able to deploy evidence from his GP or from his own experts, possibly, about risk, which would better inform his refusal and his fears, then he may well have maintained his damages. In 1983, we come across a case, the first case of somebody who is not a manual worker. So the cases from 1920 to 1983, all of the cases concern men and manual workers. Mr. Salvanayagam was a university lecturer. It's a Privy Council case, and the Privy Council declined to criticise this gentleman who was a university lecturer, who declined neck surgery despite the limited risks and good prospects that the surgery had. Now, it may have been, and my sense is that this is a classic case. You could put it down to the comorbidity. He's the first man who appears in the cases with a comorbidity, namely diabetes. Now, that is not dwelt on in the law report, but of course it could have been dwelt on far more now that we know that people with diabetes are more prone to hospital-acquired infection, and they may fare worse in the hospital environment. I take the view that it's more of an indication that a university lecturer was thought to have been making decisions about his own life on perhaps a slightly more sophisticated basis than the working men in the past, where the decisions have been more patrician. But in his case, he was not, he didn't have his damages reduced. Then we come to the opposite result in 1991, a case called Singh versus Lyons Maine. This is a tricky case. The judge at first instance, Mr. Justice Hurst, decided that, as you can see, that the surgery that the claimant declined was complex spinal surgery, and the judge accepted evidence from the consultant surgeon called by the claimant that, quote, the operation would likely be successful, and all of the doctors and specialists were largely adverse to the claimant's own view and own fears. The claimant was scared to death, and the judge says, I do not blame him for that. Well, he didn't blame him to the extent that he brought down the guillotine on his damages for not having the surgery. And the Court of Appeal, endorsed that view, and as you can see, that's a great example of a significant success for the defendant, because they had marshaled the medical evidence carefully, and it was a situation in which Mr. Singh's side had not taken the court through the risks and the benefits of surgery, and the possible outcomes. We'll see in the case in 2002, which is now probably the leading case, Geeston Lansiquot, that in that case, the court really did hove onto the dangers and the risks and the fact the claimant hadn't been advised sufficiently about them in making her decision. But Mr. Singh it's a case which is often deployed. I often deploy it when acting for a defendant, because it does show the Court of Appeal's authority for a claimant declining highly invasive surgery and yet having his damages curtailed. So then in 2002, we've got surgery for nerve root entrapment being rejected by the claimant. This was a working age ship manager who fell over on a ship. She suffered a back injury. She'd already had spinal decompression. She was represented by James Dingemans. You may well have come across him In practice, I was against him a couple of times in practice. He was a delightful guy to be against. And he then did one of the great public inquiries, and he's now in the Court of Appeal. In that case, the Court of Appeal said the following, that the surgical procedure is likely to succeed. That was a finding that was made by the trial judge. And it was the only means of relieving the plaintiff's pain and disability. Surgery was successful in most cases, but the surgeons could not guarantee a cure for back pain, and there was a percentage of patients who did not benefit. None of the doctors had attempted to quantify the chances of success or of risks of worsening of the lady's condition, or on what the worst outcome of an operation might be. So if I just pause there, you can see that the court picked up several of the points, particularly that last one, which wasn't involved in the Singh case. And if you're trying to distinguish Singh, that's the way I think to do it. And the court stepped in. This is a very powerful panel of the Privy Council. Lord Bingham, Lord Stayne, Lord Hobhouse, Lord Millett, and Lord Scott. It's very powerful. And the judgment here of Lord Bingham ended by saying as follows. It's one of the great quotes in this area. There is nothing in the evidence to suggest that she was put in a position to make so momentous a personal decision in a rational way, still less that it was unreasonable of her to prefer the ills she had than fly to others she knew not of. Believe me, that is a powerful quotation to take to court when dealing with this issue. And whilst you can't rest on your laurels as a claimant, and you do have to marshal the evidence, that quote will go a long way, I think, in the right case to assist you in showing that the claimant's refusal, especially with invasive treatment, is not unreasonable. Let's just deal with one case in 2004. This is the case of Grandpa Simpson in the Mayors and City Court, Edmonds and Lloyd's TSB. In that case, the claimant had refused spinal injections, and the reason she gave were that she was anxious about the injections, and that was a reasonable anxiety. There'd be no guarantee of success. Again, who gives a guarantee? What doctor gives a guarantee? I mean, it seems odd to marshal that as an argument when it can virtually never be said. Crucially, her own GP was skeptical of spinal injections and had advised her of that. And I think Mrs. Edmonds is a lady who'd seen her GP 10 times to discuss these issues. Her own specialist within the litigation had never suggested spinal injections, and the expert who had recommended them considered that her declining them was reasonable. Now, again, that's a make-weight argument. If you ask most surgeons, well, is it the claimant's decision or is it unreasonable? They'll say, well, it's her decision. So that's a make-weight argument, I think. But the two crucial arguments there, her GP was skeptical and she relied on her GP and had a close relationship with the GP. That comes through from the report. And her own specialist within the litigation didn't advocate that treatment. If her own specialist had advocated the treatment, you might have had a different decision. But on those facts, His Honour Judge Simpson said that she should have had the treatment, and not doing so curtailed her damages, and the Court of Appeal reversed that finding. So we then come on to the two most recent cases. These are absolutely fascinating judgments. One, the case of Stansfield, is a decision of Mrs. Justice Yip, and the second, Mathieu, is a case this year, which is a fascinating case on a whole raft of matters from Mrs. Justice Hill. If you read one case this year, make it Mathieu. It's an absolutely fascinating case with a lot of elements in relation to provisional damages, costs, Part 36, the foreign tax implications of personal injury damages, the works. Let's go to Stansfield first, to my paragraph 17. This is a case in 2021. The TV presenter of a case called Bango's The Theory, you may have seen. The judge described what the claimant was getting up to when he was injured, as she described him being used as a human crash test dummy. So, unsurprisingly, the human crash test dummy TV presenter suffered a cluster of physical, cognitive, vestibular, behavioral, psychological problems. His life was, the judge found, substantially impoverished, but he had declined to take antidepressants recommended by his own psychiatric expert. He just didn't want to take antidepressants, but his own expert had said, look, these will help you, in my opinion, and the defendants, perhaps understandably, had obtained but not served psychiatric evidence. So on that basis, the judge had a potentially difficult decision to take. And what the judge found was that the decision was genuine. It was part of the complex presentation of the claimant, and the presentation was the natural consequence of the combination of injuries he'd suffered. So all of his injuries, the pain, the psychiatric injuries, they would reinforce one another, and their overall relation to one another made it a complex presentation, which meant that the threshold for criticizing his decision was higher. And in that case, there was no clear evidence of benefit. Now, that's important because what I called earlier on relevant benefit. The claimant's psychiatric expert said he thought there would be a benefit, there would be an improvement, but the question for the judge was, and the question that the judge took on board was, I'm just not sure how much benefit would be achieved. And in trying to judge the unreasonableness of the refusal, that's a very relevant consideration. So matters were unclear. So in 2022, in Mathieu, the court also rejected the defendant's assertion. The defendant said that it was unreasonable for an artist who had been injured to refuse antidepressant treatment instead of over-the-counter medication, because the judge found as a fact that taking the medication might promote further drowsiness, and that the drowsiness was likely to dull his creativity and increase his cognitive decline. And linked to that was the increasing cognitive decline linked to dementia. Now, there's a fascinating issue about provisional damages in that case, which the claimant wholeheartedly lost in relation to dementia. But as regards the decision not to take antidepressants, the claimant was found not to have been unreasonable to have just continued with over-the-counter medication. And again, there was a separate reason for that, which I'll come to in a moment when I just sum up these principles. So going back through the cases, I haven't trawled through the cases since the 20s. If you want my overall notes going back to those cases, which are a little more detail, then you're very welcome to them. Just contact the clerks. I think that the principles are now pretty clear, and Geest is a great case to take on board, plus Stansfield and Mathieu, because they set out all the principles. But let's just have a stand back and have a last look at how the principles work, taking a broad view. First of all, I've called these treatment factors. How invasive is the treatment? Yes, I said you couldn't just apply the rule of thumb that any invasiveness is something the claimant can reject when it comes to treatment. You can't. But the more invasive, the more difficult it will be for the defendant to prove unreasonableness. Associated risks, of course, that's invasiveness, and the associated risks will go together. So you have somebody who, I had a client who was 63. She was a dinner lady, highly sophisticated. I settled the claim 10 years ago now against Christopher Purchase. Didn't get on with him at all. Singularly unpleasant and rather sneering approach to my dinner lady client, who was, as I said, highly intelligent. She'd had a multiplicity of injuries. She'd put on considerable weight, and she was obese at the time of the settlement meeting, and that she had no opportunity, because of her leg injuries, she had virtually no opportunity to reduce her weight to a level where it would be safe for her to undergo surgical treatment. She needed some treatment for stenosis, and the defendant's view was, oh, she'll have it when the claim's settled, and or it's unreasonable for her not to have it. And so I marshaled the cases together and got advice to say that in her condition, with morbid obesity, she was a high risk for anesthesia, and she also had a whole host of comorbidities, which meant that surgery was going to be highly unlikely and highly risky. So it wasn't unreasonable. In fact, my Christopher Purchase got Matthew Boyle, who's a really able barrister at Crown Office Chambers, to look into it for him so he could try and win the argument. And he came up with the unreported case of Singh and Lyons Maid. And then we had a set two about that. And as you can see, that gave rise to quite a lot of thinking about this subject. Anyway, we've got then we go on to the likelihood of success and what it actually means. And we'll come back to that with Stansfield and Mathieu. The defendant's going to have to show that not having a surgery has consequences which can be identified. If the defendant can't prove that, unreasonableness will not really matter. So the defendant has to go a long way to prove what the claimant ought to do and the consequences of so doing. And as I said earlier on, depending on the risks of surgery, if you're for a claimant, you really want to focus on the fact that if there's a 70% chance of success of some sort of treatment that the claimant still doesn't want to have, there is a 30% chance of failure. Well, what does that failure mean? And how does the court factor that in to the estimation of damages? So that was the meaning of failure. Mrs. Geist's case I mentioned above. Then the relevance, strength, and unanimity of advice. So in one of the cases, the leading cases, a House of Lords case in 1947, Mr. Steele, he decided to follow a third opinion against a fusion operation for his ankle, which was contrary to the opinions given by both experts in the case, and his own treating surgeon's view that he could return the claimant to having a strong, stable limb. Now, the claimant provided evidence from a third opinion, treating expert, that said he thought that it was perfectly reasonable not to pursue the treatment. And the House of Lords, unusually in that case, because it was a manual worker in the 40s when they were being very paternalistic, as I said, upheld his refusal, said it was reasonable. Then we have the relevance of treating doctors and GPs' view. In Count, the 1920 case of a minor, the workman's medical advisor advised against two procedures, including the amputation of the tip of the thumb. And because somebody medical had advised on that, the Court of Appeal endorsed that opinion. And Mrs. Edmund, as I mentioned to you earlier on, had a strong relationship with her GP, who quotes, and the judge accepted that her evidence. So the GP didn't appear at trial, but the claimant, as she's perfectly entitled to do, gave hearsay evidence. And in her evidence, she said, and the court accepted, that the GP had said that she more or less would not benefit from the spinal injections. And that the court accepted. And on that basis, the Court of Appeal decided, reversing Judge Simpson, that her approach was entirely justified. Then how the prospects of success are expressed. Again, whichever side you are on, there are ways of expressing the prospects of success, whether it be a percentage, whether it simply be in language. So in Geist, there were lots of phrases for success, but far fewer percentage expressions. Whereas in a couple of the cases, as you've seen, the courts have had, in one case, several cases, you have had defendant upper limb surgeons in two cases saying a 90% chance of success. Now, you do need in your cases on either side to work out how best, within the CPR 35, how best and most appropriately one can express the prospects of success. Then we have claimant factors. I'll just run through these. I've already mentioned several of them. The relevance of success having a material impact on the claim. I'll come to that in a mo. The claimant's age, as I said, most of the early claimants were in their 20s or 30s, And there's a distinct impression that the court is pick up your bed and walk. Get in there, have simple surgery, and get back to work. And that doesn't really end until the case of the university lecturer, Mr. Salvanayagam, in 1983. Constitutional factors, I've mentioned diabetes, obesity. One comes to the situation, if you, for example, in a case where someone has a severe knee injury, they often put on weight after an accident, especially if they're then immobile. If there's a fairly strong body of opinion that that person should have surgery for a knee replacement, which will get them back to work, but the person is then pretty morbidly obese, what will the court do? Will the court say, well, look, you've got to go on a diet, or you've got to take up smoking for weight loss, or you've got to take a stomach stapled? Those are all considerations you need to take into account. Don't take anything for granted. The other constitutional factors with your own claimant, you have to take into account the surgical risks, thrombosis, for example, complicating factors for comorbidities for anesthesia, and vulnerability to hospital-acquired infections. And how many people come out of hospitals in various parts of the country alive? I know that may sound stupid, but if a claimant goes to see their GP, and the GP says, actually, I wouldn't go to that bloody hospital to have an operation, and that's where the claimant lives, that's got to be a factor that can be included in the wide range of considerations. In Stansfield, the case about the human crash test dummy, Mrs. Justice Yip commented on the claimant's unwillingness to take medication for depression, and she said, that cannot be viewed as a simple matter of prejudice or personality. Rather, it was part of the claimant's complex presentation. I touched on that earlier. And again, that's something that you must take into account. We all know that the psychosocial model of pain, and you have to look at all of the factors involved when a claimant decides not to have certain treatment or decides to have certain treatment. So just going back then to the point I've raised it a couple of times about what the defendant has to prove. It's not just a question of the defense proving that the claimant ought to have certain surgery and then counsel being carried shoulder high out of the court. The burden of proof doesn't stop at the refusal being unreasonable. The defendant must substantiate its alleged impact. So in Stansfield, the court said this, even if I had found that the claimant had acted unreasonably, it was not clear how the defendant contended that this should be reflected in the claim. Counsel was unable to assist, despite bearing the burden of proof on this issue. The defendant called no evidence on it. So counsel is asked the question, how should I do this? Now, I'm sure counsel in that case for the defendant was Marcus Dignam, very capable counsel. I'm sure he did try to assist. You get the distinct impression. In Stansfield, no, he was in Mathieu, sorry. I can't remember the counsel in Stansfield. But I'm sure counsel tried to assist in that case, but they were obviously unable to assist the court enough to show that the antidepressant medication would have made a difference to the claimant. Now, of course, they had their own report, but hadn't served it. So they hadn't asked their own expert questions. Their own expert may have been taken a different view, of course, to the claimant's expert, but they hadn't posed questions to the claimant's expert to extrapolate from the claimant's refusal, or what is it that you would expect and anticipate the claimant to achieve with antidepressants. So they hadn't gone far enough. And in Mathieu, this was the case where Marcus was defending. Mrs. Justice Hill decided that antidepressants might have improved the claimant's headaches, but there was still uncertainty about its impact upon his sleep, his fatigue, and his creativity. He was the artist, you remember. And there would not have been, even if the refusal had been found, there would not have been a sufficient evidence base for reducing the claimant's losses. So for a defendant, you have to go the extra mile. The last point, it's a funny case. It's called James versus Woodall Duckham. Michael Davis QC he was a ghastly man, went onto the High Court bench, and an absolutely terrible and grumpy golfer. Acting for the defendant in this case, had a fantastic result, you may think. It's a case in which the Court of Appeal substantially reduced the claimant's damages, deciding that a trial that took place in 1968 ought to have taken place in 1965. So they reduced the damages accordingly. So this is a real throwback to the patrician attitude of the court, and it was endorsed by the Court of Appeal. So what was said in the judgment was that the claimant had grave pains all over his body, which entirely prevented him from doing any work. But that cannot be expected and the neurosurgeon said this, they cannot be expected to clear until his action has been settled, following which I do not think there will be left any persisting serious disability. That's a neurosurgeon talking about all over body pain. Now, I know that some people think that anaesthetists can't help in a case. I had His Honour Judge Charles Harris, now retired, saying, Mr. Benson, what is an anaesthetist going to say which might help me? Well, we know that anaesthetists are now almost all in the field of personal injury pain experts. There are also rheumatologists that comment on chronic widespread pain, fibromyalgia, but very often it's the province of pain experts. In this case, classic throwback to the past, the expert was a neurosurgeon, and he said that the claimant's body pains will clear up when his action is finished. Now, we know that there's plenty of psychiatric evidence, and there are papers to say that the pressure of litigation, the stress of litigation, can have a very considerable effect in the right case on the right claimant, and that the end of litigation can set the claimant free in some circumstances and can enable the claimant to take steps forward that perhaps even subconsciously they're not able to take during the case. But I wouldn't take away the principle in this case of a neurosurgeon should be commenting on chronic widespread pain. What I would say is keep an eye on the case, keep an eye on the fact that delays in bringing a case which have extended a period of compensation, when the evidence is overwhelmingly that compensation should have been curtailed by a certain time, that remains a highly relevant factor within the ambit of the subject matter I've been talking about today. So I've just been instructed in a case where a claim in relation to a child occurred when the child was 10. To my mind, there was no good reason why the child ought not to have been successfully, crisply, conclusively treated within 1, 2, or 3 years of the accident, but we're now 12 years later. And it may well be that the treatment is hugely complicated by that lapse in time. Now, we'll see what happens in that case, but I've had plenty of other cases where I've been fighting to show that that sort of delay, in particular in relation to a child, was something which was relevant or irrelevant, depending on which side one was fighting. Thank you very much for your attendance. I'm hoping that we may have some questions. And I will, if you have any questions, I'm just looking down at the comments. If there are any questions, please fire away, and I'll be delighted to try and assist. And please tell me who you are when you're posing a question. Yes, somebody's just sent a note saying, as far as delays, pandemic-related rehabilitation delays aside, of course, I quite agree. There are plenty of consequences in the pandemic. Gary, thank you. There are plenty of consequences following on from the pandemic, which we still haven't worked through, but certainly any delays related to the pandemic are not going to be visited on the claimant. So I will give it another couple of minutes for somebody to come up with questions. Otherwise, I will probably leave it there. The last time I invited questions was in front of Sir Francis Aughton, Lord Justice Aughton, in a criminal case where, when prosecuting in 1992, I had allowed the court to pass what turned out to be an illegal sentence of imprisonment. And it was I was asked a question by Mr. Justice Blofeld, which was pretty tricky. And Sir Francis Aughton said that I had the look of Mike Gatting about me as he asked the question. And I only saw later in the Times that day a picture of Mike Gatting, who had just been hit in the face by a bouncer and the whole of his nose had split. So I obviously hadn't entirely impressed the Court of Appeal. Anyway, in the absence of any questions, I will say thank you very much for attending and have an excellent day. Thank you.